DJ LeRoy.
NightWatchman, how you doing, buddy?
I'm well. How are you? And well
Good.
is a good word to start this show off with.
Absolutely. When we're talking about wellness, absolutely.
Yes.
And remember, NightWatchman, both you and I are both seniors, man. So there's certain maladies that we should all be concerned of.
Right. And you're more senior than I am.
Why do you keep bringing that up? Why? Because you can. Is that
you
it?
get a bigger discount. You get an extra % off at the movies.
No more. Well, anyway, man, let's definitely talk about some of the common maladies that affect those who inhabit the Republic of Harlem.
Okay.
But also,
we're
I want to know.
Republic. Are you? You're not Republican though, are you?
Oh wow! You're bringing some heat this evening. I see.
We got to keep it spicy,
Yeah, yes, indeed. Well, you know what? We're definitely going to have a couple of veterans and also a newbie. I think I'd like to actually bring out this newbie and hear about him because he's been also tackling some of the maladies from across the waters, man, in the motherland. Okay.
All right.
Yes, it could only be Zacharia. Kafuko, how you doing, buddy?
Right. Thank you. How are you? Thank you for having me.
Yeah, absolutely, man. As a matter of fact, you were recommended by one of our good friends, Dwight Smith. So hey, you know, we got to do right, buddy. We got to do right.
Yeah, thanks so much. Thank you.
Absolutely. And also, welcome back because I understand you were traveling and got back recently.
Yes, I'm now back in New York. I was in Africa.
Absolutely. And you're going to be telling us about the work there that you're doing there in Africa, okay?
Absolutely.
Beautiful. Next up, we have a young lady who is, I guess, talking to us remotely from a vehicle because she's going to this fire, to that fire, tackling them all. It can only be Deborah Levine. Only. Yes.
Good morning. Good afternoon. Good evening, wherever you are in this universe.
Yes.
That's right. Time has no place in
there
our
you
discussion.
Go.
Okay?
That's right.
There you go.
Absolutely. So you're going to definitely be talking to us about the Harlem Health Initiative. Okay.
Yes, at the City University Graduate School of Public Health and Health Policy, your public graduate school.
Exactly. And you're going to talk about how seniors like the NightWatchman and I, how we are on that spectrum there. Okay.
We call them seasoned individuals. It's the wisdom.
All right. I like that.
Exactly. And I know, NightWatchman, she's talking about me. But anyway, on the next note.
Yeah, you're salty. You're definitely seasoned.
But of course, two things. We got to talk about one of the best Ethiopian restaurants on the planet that's located where? In Harlem, baby. In Harlem.
All right now.
But we're bringing him out now because we want to talk about health. It could only be Padmore John. What's up, Padmore? There you go. Go ahead, buddy.
Good. How is everybody doing? Good to see you all. Thank you for the invite. DJ LeRoy, NightWatchman. Good to see you again, Deborah, Zacharia. Nice to meet you.
All right, absolutely. So, okay, let's get this popping. So, certainly we do know that all people are not created equal. And we certainly do know that all built environments are not created equal. So, certainly, Zacharia, you have to tell me about the work that you've been doing over in Africa and why malaria, who, you thought that was something in the past, but it has made a resurgence, and in what specific countries in Africa it's really attacking.
Yeah, thanks a lot, Curtis, and really excited to be here. So, getting to malaria, I think a lot of people in the United States, I think for majority of people in the United States, malaria is just like a story that they've heard or seen in the movies, but in Africa, it is a real problem. On average, there are about 248 million cases of malaria a year. Yeah, that's a lot. That's absolutely a lot. And then this translates into a global death toll of about 600,000 per year. And you'll be interested to know that majority of these deaths, I'm talking about 95% of these deaths in malaria are actually in sub-Saharan Africa.
Wow.
And interestingly, or sadly as well, from this 95% death to out of the 600,000 that we're talking about, over 75% of these are actually in children below the age of 5. So you can kind of see the problem. It's actually affecting largely children before they hit their 5th birthday, which is accounting for about 75% of the deaths. Now, on a daily average, this would translate into about 1,000 children dying of malaria every day in Africa. So the burden is huge, and the work is cut out for us because of this. In particular, I've been stationed and I've been doing in Zambia, where I was born.
Nice. Okay.
Yeah. But beyond that, we are also doing work to support governments, to support communities, and also begin public engagements on the rollout of the new malaria vaccines. You may be interested to know that the WHO, that's the World Health Organization, now has 2 recommended and pre-qualified malaria vaccines. The latest of them is R21, which was developed by Oxford's Jenner Institute in the UK. So this particular one was recommended in October, and it got pre-qualified in December on the 22nd. Now, just for context, pre-qualification for a medical product by the World Health Organization means that it underwent a rigorous testing process to ensure that the quality of the vaccines are actually up to international standards. And by this happening, it allowed international bodies like UNICEF, which normally does work for children around the world. So it opens the way for UNICEF as well as Gavi, the Vaccine Alliance, which buys vaccines for low and middle income countries to actually begin to make purchase orders. So right now, apart from Zambia, we are doing work in Kenya, we are doing work in Burkina Faso, in Ghana, we are also doing work in Tanzania. Now, you obviously maybe are already up to speed with this, but these are some of the high burden countries on the continent of Africa. With the inclusion of the Democratic Republic of Congo, they account for the majority of the cases that are recorded on the continent for malaria. So definitely a lot of work is necessary. A lot of work still has to be done.
Beautiful, brother. Thank you for that, man. And like I said, a night watchman, we're talking about essential workers, okay? Literally. Go directly. So certainly, Deborah, and you, I want you to chime in. Certainly, we do know that Harlem has a certain set of maladies that are affecting our community. I know about, let's say, heart disease. I know about, let's say, asthma. I know about certain high blood pressure, of which I am also one of those people. So tell me, what have you seen on the ground?
So I think it's no surprise. Still recovering both from COVID and monkeypox and isolation. Mental health concerns are very much a hot topic in the community. Not just the severe and persistent mental illness where you see people who may be talking to themselves or are homeless, but the whole notion of anxiety and depression and functional anxiety and depression. And so super grateful to Padmore and Harlem Hospital Community Advisory Council, Community Boards 9, 10, and 11, and 12 will be putting on a webinar May 1st looking at the state of mental health in Harlem and featuring Harlem Health's outpatient services and how people can access them. Really trying to find some support for everyday individuals and helping them to address the stigma around mental health, and also understand that there are support systems in place and different types of behavioral health interventions that our community has that are available. So that's definitely one of the hot button issues. For those that don't know, April 11th through the 17th is Black Maternal Child Health Week.
Wow.
And Black women are, and I believe this was the stat that just recently came out, are almost 9 times more likely than their white counterparts to be impacted by maternal child health issues and child mortality. So we've got some work to do in our community, and I could sort of go on, but yeah, there's a lot happening, and we sort of have to work smarter and more collaboratively to sort of address and use more of our resources in our communities. So super excited to figure out more ways to link the conversations of helping people find access to care.
Excellent, excellent. And yeah, you know we're coming back to you. No worries. And of course, Padmore, do tell, because you know people out there in the community just think of you as a restaurateur, but you're so much more. So tell
Yeah,
us, bro.
and thank you for that, DJ LeRoy. And to the point that you made when you started up this conversation, was one of the things that you said was the built environment, and that's one of the most important things that we have to consider in terms of health. So, as Deborah was saying, there's a variety of challenges that we're facing health-wise. One of the key things that especially the agency, the Department of Health, is looking at is what has happened post-COVID. So in 2019, we were looking at life expectancy being around 82 years, thereabouts. And then it dropped significantly in 2020. Of course, we all know why, because of the pandemic. And it is still taking a while to get back up to those 2019 numbers. So, and part of that has been, we have to, being in Harlem, right? The Mecca of Black culture. They're celebrating nearly over 100 years now in terms of the Harlem Renaissance. We do have to talk about another thing that happened back in the early 1900s, and that's redlining. Redlining in the 1920s, the Federal Housing Act. Caused one of the most, and then certain other under-resourced activities that was done by the federal, state, and city governments really put us in the space where we are right now in terms of some of our health outcomes. When you look at a map in terms of where predominantly redlining was, especially New York City, and you overlay that map of the redlining with some of the worst health outcomes in New York City, it almost matches up perfectly. So something that happened in 1920 that was an economic health outcomes over 100 years later. Wow. So we have to look at see how what impact. So in order for us to address them, and we could talk very specifically about some of the things, and Deborah speak to that. We're seeing heart and diabetes related diseases, right? That is increasing as causing some of these outcomes. Deborah mentioned mental health, and we're seeing that in some aspect of our substance use, as well as suicide. Now, one of the highest suicide rates across the country is in youth, African American youth under the age of 21, right? Wow. And this is something new. So it's very, and part of that does come from a little bit of the what we saw during the pandemic, where we were seeing a lot of individuals being by themselves, and we were seeing a little bit more individuals who are alone, who are isolated, and being able to address that is very key. So to do that, the New York City Department of Health have launched a campaign that we're calling Healthy NYC. And Healthy NYC is looking at a few key items in terms of how we're looking to address that. Some of them are COVID-19, as I mentioned, heart and disability related, diabetes related diseases, screenable cancers, right? You were talking about being a senior, not quite a senior, I heard it, but getting on in age and being able, especially for men, for doing prostate cancer screening, women screening. So that's something that's very important, and sometimes we do not do the appropriate preventive care to address that. Amongst the Healthy NYC campaign is also drug overdose, as I've said. Homicides. There's a lot of violence that is occurring in our communities because to some extent of mental health, because to some extent of just the challenges dealing with the variety of changes happening economically across the country, across our city at the moment. I mentioned the increase in suicide, and as Deborah had mentioned, pregnancy-associated deaths among Black women. It is a very much of a big challenge that it's very difficult for us to try and get a manage on right now. But the good thing is that there are, as Deborah was mentioning, there's a lot of collaborations coming together, coordinated efforts by the Department of Health, by community-based organizations, by institutions like Deborah's and others that are now working closer together for us to be able to address this comprehensively.
Excellent. And Zacharia, certainly we do know that COVID was a global pandemic, no doubt about it. But now, and you're going to help me along this train in terms of understanding malaria. So I understood, okay, we're talking about mosquitoes.
Yes.
Okay. And of course, with COVID, we were talking about an aerosol transmission. With malaria, how is that spread? And what would some of the symptoms be? And if it's diagnosed earlier, what is the survival rate?
Right. Thank you for those questions. So you're right. Malaria is caused by mosquitoes, specifically the female Anopheles mosquito. And there are different species of these malaria-causing mosquitoes. But the most common and also the most deadly is Plasmodium falciparum, which is very prevalent in sub-Saharan Africa. So from that perspective alone, once a person who has malaria is bitten by a mosquito, this mosquito basically gets some of the parasites from that person, and when the mosquito lands and bites another person, it basically transmits or transfers those parasites into a new host, basically for reproduction purposes, where it incubates and begins to reproduce, and the parasite begins to grow there. So this person also is infected, and if another mosquito bites, it basically takes to another person. So the transmission continues in this pattern, which obviously also gives us an indication of some of the ways that it can be prevented. But largely, that is how it is transmitted. It's a blood parasite, which is transmitted from person to person through mosquito bites.
Wow.
Some of the common symptoms for malaria include, fevers, shivers, headaches, pains in the joints. For some people, it also manifests through, alimentary canal complications, where people vomit after they eat, and severe headaches and things like that. I've actually had malaria myself first when I was still in primary school, and even in later years. And I tell you this, that it's not fun. It's absolutely fun. Yeah. So those are some of the common symptoms. But like I mentioned earlier, these symptoms become more severe among children because the immune system for children, especially when they are born, is still developing. It's weak. So the impact or the immune impact for the malaria parasite in the bodies of babies, for example, is more severe, but it continues to reduce as they grow older. So the threshold is cut at about 60 months or about 5 years. The risk is quite reduced by that. But when they are younger, it's more serious, and which is why even now 75% of the deaths in malaria are actually in children below the age of 5.
Wow.
You can also kind of imagine, what impact, and I'm also going to refer to what Deborah has mentioned. What impact is there when mothers have to bury their children? It's a sad reality, and I think a lot more work has to be done, to stop the spread and prevent these deaths, thanks to the new vaccines. Now, so what are the survival rates? You ask if it is diagnosed early. Before I respond to that question, I also want to create some context, especially where the malaria problem is a big deal, where the burden is high in Africa. Majority of times, people or children are diagnosed with malaria late. That's a problem. Number one, Africa does not have as many health infrastructure and facilities like the developed world has, and secondly, even the health facilities that exist are quite a distance usually from where people are living, especially where the transmission rates are high in the remote rural areas. So by the time that the child begins to show symptoms, or when they become symptomatic, usually it's either a minute, a day too late, and by the time they get into to the health center, it's already almost too late. So it's important that diagnosis is done quite early. Now, with regard to the specific survival rate, the most closely reviewed data that is available that we have seen on the survival rates is based on the RTSS vaccine, which was produced by GSK and has already been piloted in 3 African countries, including Malawi and Burkina Faso. So based on that data, for children that got vaccinated for malaria, the survival rate jumped from, basically it was increased by 13%. I know it doesn't sound like a lot, but when you consider that there are over 600,000
deaths, that's a lot of numbers. Yep.
Thousands of children saved. The modeling that we are currently working with, which is based on the R21 Matrix M vaccine, as I mentioned, which was developed by Oxford in the UK and is now being manufactured. The vaccine is being manufactured by the world's largest vaccine manufacturer, which is the Serum Institute of India. So the projection for this one, the model is suggesting that for every million children vaccinated with R21, we are talking about 6,000 children's lives saved. So for every million vaccinated, 6,000 children can be saved. In other words, they are prevented from death. So again, context-wise, 6,000 out of a million vaccinations seems like a small number, but when you consider that these are actually families, these are babies that are loved by their parents, 6,000 for a million vaccinations is still a huge number. So if you vaccinate, for example, 40 million children, then effectively you have saved over 240,000 children's lives that get to go to school, that get to live their dreams, that get to pursue their careers. So I think the human angle to the campaign is significantly important when we engage, in this kind of work. I think I'll pause there for now.
Well, I guess one of the other things I have to know. Okay, so you gave those particular numbers, and certainly we hear about vaccines. So certainly, Black people in America have a different relationship as it relates to, let's say, the medical community and vaccinations. So has there been any hesitancy by the people in these various countries to vaccinations?
Yeah, that's a good question. So stemming from what we saw during the COVID pandemic, there was, hesitancy towards vaccinations, and there still exists pockets of hesitancy in different communities, especially, the marginalized remote communities, even in Africa. And even now, as we are doing this work, as we embark on this campaign, these are some of the considerations that we are taking with us. So part of the campaign is focused on public engagement, so that the community is prepared in advance of the arrival of the vaccines, because obviously vaccines cost money.
Yes.
Just for example, the RTSS malaria vaccine produced by GSK costs about $10.20 per dose,
Wow.
one dose, and it's a 4-dose regimen. So children need doses for them to be protected. So we're talking about $40 just for a child to be protected, right? And for the 21, it's much cheaper. It's about $3.90, but still that's a cost. So the idea is that if millions of dollars are being spent to purchase vaccines for children, millions of dollars are being spent in the distribution and logistics, framework for this deployment of the vaccines, then we must also move ahead of the curve to make sure that the communities for which these vaccines are being prepared for, that these vaccines are being, shipped for, are ready to accept. So public and community engagement remains critical.
Yes.
But I also say for malaria, especially in these sub-Saharan African countries, it's a disease that has plagued communities for decades, right?
Yes.
The earliest cases of malaria on the continent were in the 1980s, in the 1800s rather, right? So the disease is not exactly new to these communities. So there's arguably a better reception to vaccines for malaria and malaria countermeasures as compared to other diseases, because, as I mentioned, this is a disease they've lived with. They've seen what it can do. They've seen people within their communities that have been, getting into research, getting into, mitigation efforts, such as, distribution of insecticide-treated bed nets, seasonal malaria chemo prevention, such as indoor residual spraying. So they've interacted with countermeasures for malaria for a while. And because of that, there is at least a better understanding on what the potential value of a malaria vaccine is, because they know what malaria is. They've seen their children dying. They've seen their neighbors lose children. So the sale is not a hard one when it comes to that. But obviously, we can't take anything for granted. And community engagement, public sensitization, and media engagement is critical for buy-in, so that we increase the acceptance rates for vaccines, so that we obviously do away with vaccine hesitancy.
Absolutely. And of course, Deborah, you heard that. And because remember, you are boots on the ground. And certainly with COVID, no, we have not been dealing with that or as many decades and centuries as malaria over in Africa. So with COVID, it hit us like a ton of bricks. Okay, we weren't used to this at all. And one of the things that absolutely was never addressed early on was the mental aspects to that, to that virus. So please, Deborah, education, getting people, let's say, accustomed to, as they say, the new normal. What have you seen?
So I think a few things. I think we have a lot of education that we still need to do to address sort of the stigma that's associated with having these kinds of conversations. I think it's going to take more than just us offering people an opportunity for vaccines. I think we have to have trusted individuals who can share their experiences and work with community, because it wasn't just COVID. I mean, we are still struggling with adult vaccines and childhood vaccines. And Padmore, we haven't caught up yet. Am I correct? Are we still lagging in terms of routinized vaccines?
That's correct. That's correct, Deborah.
So
just the basic protection and not just but really talking to parents and caregivers and grandparents who are caring, but from a whole family perspective about wellness and what does wellness mean and how do you do that. So I think to your point, we have some catching up to do, and we're still in recovery mode. And the truth be told, we weren't at the levels we should have been before COVID. So I think it's sort of a layered on effect. Padmore, we've had some of these conversations. I think the house was on fire before COVID. And now COVID just made it spread and made it more evident as to where those gaps are. So more education, more access. And again, I think when we see Black and brown people who are a part of the clinical trials, when we see Black and brown professionals who are a part of the review panels, when they are the key trusted informants in our community, and we're cross-training them to not just talk about vaccines, but diabetes, hypertension, HIV, mental health. It's the intersection of how we do wellness. Because I think that's the other part of the thing that the community says is that, you tell us all the time we have the highest rates of everything.
Yes.
And that in itself can be depressing. If you know that we have, the highest rates of poverty, the highest rates of diabetes, hypertension, HIV, and we go down this list, well, that in itself. So we also have to function and sort of talk more about wellness and the centering and the good stuff, and how do we support those things like meditation and teaching people how to deal with anxiety and depression and acknowledge it, and for it to be okay. Talk therapy, and in some cases, if you need medication to help support, that we normalize these conversations. It's okay to not always feel good, and we don't always have to have the super person cape on. Because even super people get tired.
Well said, Deborah, for sure. And Padmore, man, like I said, we're definitely, like I said, advancing in age. That's one of the common occurrences with folk. We go on in age, but you within the health field, some of the things that and COVID came out of nowhere. But what are some of the maladies that you have been dealing with before that in the Black and brown communities, man?
Sure, great. Thank you for that. And so it's almost like COVID was an attack on a worn down body, right? And that's one of the key things is that, as you say, prior to that, for the way that many of us in our communities, here in Harlem, but other Black and brown communities across the U.S., chronic disease management was one of the key problems, right? So we were seeing cardiovascular disease, asthma, diabetes, hypertension, all of these that to some extent has a root cause in the environment where these individuals are staying. They're in cities that may have certain where they live, where there are certain food deserts, so they're unable to get access to nutritious foods at appropriate prices. They are far away from where they have to work, so there's an economic disadvantage for moving from one place to the next that leads them to now not being able to access healthcare and access other needs. And so this more or less was like something that was festering in the U.S. for many decades, and it just exacerbated that. Now, one of the points that Deborah made was, how can we now start to address that? One of the key things, and this was what we did at the agency during COVID, was how can we gain trust with the communities that we work with. I work out of a building in East Harlem within the Bureau, the Harlem Bureau of Neighborhood Health. And the intent is for the Department of Health to have what we call place-based initiatives that are addressing the needs of a particular community with input from the community and for us to be able to build relationships with community members, whether they're individuals or organizations, to really work together to address some of the health challenges that we're facing. There is no entity that could come into a particular community and say, I'm going to fix this for you. It has to be something where the community that's being addressed needs input, needs to indicate, and even to the point where Deborah is saying that, we're telling folks all the time, you're sick, you're this, you're that. Honestly, a lot of folks are like, we know this. We've been doing this for quite some time, but you are not believing some of the reasons why we are. I mean, we know that one of the reasons many Black women die during pregnancies that they are not listened by the physician, right? This is what happened to Serena Williams. And I'll tell you this, one of the reasons why many Black folks were not getting initially hooked on opioids was when they were entered into emergency rooms and saying, I'm having a certain amount of pain. That pain level was not being translated to by the nurse, by the physician, whatever, and believing that that person is actually feeling pain. So they were not being prescribed opioids. And that African Americans from becoming hooked on opioids. Now this happening to fentanyl, right? There's nothing like that, right? So racism was actually saving a lot of folks from becoming opioids. So part of it is trust.
Yes.
Yeah, and that underlies any intervention that any agency is bringing to any community to address any health outcome issue, right?
Yes.
If the community does not trust whatever is coming in, they're not going to believe it. So that's one of the reasons why during the response to COVID, and why now, while COVID is now becoming endemic, very much like the flu, there's still diseases that are ongoing that are causing as much damage as what COVID was leading up to. So the response to COVID was, how can we work with community-based organizations, and a key thing, community health workers, right?
Yes.
Message across that it's important that you get vaccinated, but if you don't want to get vaccinated, then you have to follow certain guidelines to protect yourself as much as possible. Yeah. If you're a person that was not going to be able, don't have to go out every single day and travel, then you can stay home and isolate for the next 6 months. Great. Right? Yes. When you do want to come out, you should become vaccinated.
Yeah.
But in order for that message to land, it has to be coming from a trusted messenger. And then the folks who are receiving that message have to have some belief that the person actually is doing this for our general benefit and welfare, right? So I think that was important. So now a lot of the work that was done by community health workers in terms of getting that message around vaccination around, right? While it's still important, because as Deborah was saying, vaccination for other diseases is still not where it needs to be, especially for young children now entering the school systems, now entering, throughout their scholastic career. So now, instead of just addressing COVID, we're like, how can we use these community health workers to address some of these chronic diseases that we have been seeing? And that was the underlying reason why so many more people were dying from COVID. So now, what are the different things you need to do to address diabetes and hypertension and asthma? And cardiovascular diseases and such. So now even that we have here in Harlem, have a program called the Harlem Health Advocacy Partnership. And that is where community health workers, in this case is being run by a community-based organization that we recently hired, but before it was done directly by us, goes into NYCHA residents, the NYCHA housing, NYCHA developments, speak to the residents, identify some of the residents that have, the hypertension, diabetes, and asthma challenges in terms of their management, and do one-on-one health coaching, and work with them to give them information about how to manage their disease, try and get them a little bit more aware of some of the resources that are available in the community, work with them to actually address some of the built environment, because as I said, the built environment has a very big impact on our disease outcomes, and then to collectively build resiliency among the community. And that's something that's really important, is that how we are taking care of those who need that support right now. We are strengthening our networks, we're strengthening our collaboration, we're strengthening our individuals, we're strengthening our organizations, so that when something else happens, and unfortunately the way things are going,
something else will happen.
Something else is going to happen.
Yes. Yeah, true.
The community is a little bit more resolved to address that issue and bounce back from it, right?
Nice.
And I think so that those are some of the important things that we want to look at.
And one of the things, Padmore, I give you major props, for pointing out how health professionals, white health professionals, didn't really understand Black physical pain. Okay, because we certainly do know, and I got to give you props for having that statue on Fifth Avenue removed. Okay, regarding that particular doctor who used to do experiments on. That's right, Black female genitalia. So I forget his name. What was his name, man?
Wait, if his statue is removed, we don't need to know his name.
Oh, okay. NightWatchman, yes, very good. But go ahead.
I think it's important that we do know his name, and part of it was what happens after that, right? So it's beyond. The name is J. Marion Sims, and the way we are actually. I was just actually speaking to the artist, because an artist was identified to replace that statue, and that statue is Victory Beyond Sims, right? So that we know that some of these challenges has occurred. We know that we cannot forget the history. We cannot forget the legacy. We cannot forget the root cause of where we are. But then what are we doing to be able to move beyond that? And one key aspect about that, Kurt, is the fact that this is a mental health issue. Imagine walking by this every single day where you're seeing a representative of an ideology that denied you personhood, that denied you the recognition of your pain. And every day you have to accept that this is something we have to do. So just imagine where the mental health of a community is after that. So I think it's important that, yes, that was removed. Wherever it has gone to, I don't know. But then we need to celebrate that removal, celebrate our continuance of health beyond that.
Yes, absolutely. And you know what? So NightWatchman, bottom line now. You know, I've known you for years. You don't necessarily complain about stuff, but I know sometimes
you hear the setup already. But go ahead.
I wasn't going to set you up. You know I love you, man. You know this already.
That makes me even more nervous. When you profess your love in such before asking whatever you're going to ask.
Yeah. Okay. Then you know what? Instead, let me ask Zacharia something. Okay.
Can I get a question in that?
Yes, you can. Yes. Absolutely. Okay. Absolutely. Go ahead, my man.
So I wanted to switch gears and talk to Deborah a little bit, because she had mentioned that she is doing some education in medical cannabis, which is an interesting scenario for New Yorkers, because while there's so much in the news right now about our adult use program, the fact is that medical cannabis was legalized here in 2016.
Wow.
And yet here in 2024, less than 1% of the population of the state is participating in the program. And I suspect that the numbers for our neighborhoods are even lower. So I want to hear a little bit about what Deborah is doing with regard to education in that area.
So thank you, NightWatchman. Really quickly, the school has, based on the request of Community Board 10, Morris Meets Malcolm, the Harlem Business Alliance, folks like Regina Smith and Dr. Cheryl Smith and Charles Johnson, who have been really pushing us to work lock and step with community to create 101s around everything from medical cannabis to adult use, and to provide the science so that people can make informed decisions, working with community boards to better understand the implications of the MARTA and where we are in the process, and understanding placement of dispensaries and the whole notion behind that. But also to sort of raise this whole concept around medical cannabis and access to care, and making sure that it's one more tool in the toolkit around treatment modalities. Again, the school's position is not to tell people what to do, but to be able to create culturally competent, science-based information that people can make informed decisions so that they can have conversations with their physicians, that our providers in the community can also have a place to learn about medical cannabis and adult use, and how to integrate that into their systems, working with our community-based organizations to integrate this into their programming, because, you know, whether you like it or not, it's here. And we as a community need to think about not just the harms, but also how do we utilize and support the good. This is the first time that we have a plant that has been used for medicine, but also for recreation. It is used for sacrament in some religions. So this is a very different opportunity. It's not alcohol, it's not opioids. So we really have to also train the next set of public health leaders to be cannabis ready, so that they can do the research, they can help with evaluations, survey work, helping to design curriculum that looks at knowledge, attitudes, and beliefs. So lots of work to be done.
Nice.
Great,
Very
thank
good.
you.
Very good. Yes, indeed. So, Zacharia, what I was coming back to you for, I want to know. So let's say in the countries of Africa, certainly we do know that COVID, regular maladies, heart disease, you name it, it happens. As a matter of fact, and Deborah and Padmore, I'll come back because I understand that there has been, especially in the U.S., an increase in things that we thought we had conquered, such as polio, such as measles. You know, so tell me about some of those maladies besides malaria that you have been confronting there in Africa.
Yeah, thank you so much. So outside of malaria, we actually do have other portfolios of work that we are interested in. And one of them is tuberculosis. And I know this is also a problem in here in the US, but on the African continent, it's maybe as a result of, you know, poor infrastructure, poor expertise, and things like that. So tuberculosis is actually within the top 4 in terms of killers on the continent. I mean, there's also HIV and diarrheal diseases. So we do have a program for tuberculosis where we're supporting research and clinical trials in endemic settings. So basically trying to, you know, support and promote clinical and medical research that is taking place in communities where the problem is, by local scientists and experts who are known by the communities, who are trusted by the communities, because one of these is what actually, you know, inspires confidence in the medical products that are developed from such studies, that inspires confidence and trust in the, you know, the vaccination process or whatever countermeasure approach that may be used. We also have one for cholera, Shigella, that are part of the work that we are supporting. Pneumococcal studies also in Malawi, and the list honestly is endless. But the point I think to take home is that there are really a lot of, you know, concerns when it comes to diseases on the continent of Africa. But, you know, in many developed nations aren't such a big issue because the numbers are so low. But in Africa, those are claiming countless lives every passing day. So you can also, I guess, imagine and accept that while we do this, there's also that needs to be done, and trying to get as much, you know, communities engaged, you know, participating, I think is really, really, really critical to making sure that even if medical innovations aren't ready yet, for example, in the case for, you know, a TB vaccine that is actually, you know, potent and confers lasting immunity, apart from, you know, the BCG that is already being given. while these medical products or innovations are yet to be ready, there's also an aspect of community behavioral change that
Yes.
through engagements, education that both Padmore and Deborah have mentioned, and these continue to be meantime tentative interventions and mitigation efforts to try and reduce the burden, to try and promote better behaviors among the communities, so that even though the problem is there, we can limit its transmission, thereby limiting its burden and promoting more healthy communities.
Beautiful. So Padmore, you heard me kind of start off talking about some of these particular diseases and maladies that we thought we had licked, seeming to have a certain resurgence here. What have you seen on the ground in New York City in particular, man?
Yeah, I mean, so we have starting to see a little bit of increase in tuberculosis as well as measles. So one of the challenges, as you all know very much, is that we are getting, and I don't want to necessarily put it on this, but we're seeing a lot of different folks that are coming in from different spaces that have not been in the U.S. Predominantly as much before. And sometimes these individuals, and so these are some of what we call the new New Yorkers, asylum seekers. They're coming in, and so one of the key things that we have been doing is really at the different HERCs, the hotels where they're residing, we're going in there and checking out. Sometimes some of them need COVID vaccination, measles vaccination. There are a variety of different of diseases that we're seeing that are coming in. Some of it also has to deal with the lack of access to medical care from some of the countries they have seen. Obviously there is a global world now. A lot of individuals are traveling across the world. They're coming in a variety of different diseases that they're catching from whatever spaces, and they're bringing back here. So, which is one of the big reasons why recognition of the role of vaccination, recognition of just simply when you're filling out that form where you've been and where you're coming from, is so important in terms of tracking disease. Our epidemiology division is very busy and does a great job in maintaining on top of that. We have a immunology crew that is very dedicated to ensuring that individuals who need the vaccination are able to have access to that. And it's something that we're doing and being on the ground for as much as possible.
Well, Padmore, I guess as you said, definitely we have these things going on. So what might be a recommendation that you may give for the population, so to speak, and also not quoting the Orange Man. Remember what he has said on his platform about they're bringing disease, they're bringing crime, all this particular thing. You're not saying that, but you are saying something different. So clarify.
Yeah, it's not a matter of, look, if anyone who's coming into the country, whether they're coming in legally or illegally, can come with anything, right? So let's not just say that it's only the illegal immigrants that are coming in with a variety of diseases and they're getting us all sick. People travel every single day on an airline in a legal manner. They go somewhere, they interact with the locals, they interact with somebody over there, and you have no idea what you may be contracting. Just the other day, a physician friend of mine, he traveled and he told me he ended up getting malaria in his travels. So it's right. And he's a physician. He knows how to take the appropriate precaution, but there's some things you just can't do. So it's not a matter of sticking blame, but making sure that those who need the appropriate care have access to it. And this is part of the messaging that the agency is doing, the Department of Health, in terms of making sure that folks know that when they're coming from certain countries or traveling from certain regions, there's a need for you to take appropriate precaution. There's a need for you to appropriately vaccinate. We're seeing, and this is part of this larger fight in terms of gaining trust with the medical system. We know that this is something, especially the legacy of what has happened with African Americans in this country, that part of that lack of trust occurs. But this is one of the reasons why we're trying to make the claim that it's important that folks to have this sense of care for themselves, but also for the community. We saw from COVID that there's very little that we can just maintain within us, within our household. That there is, it's a global community now. We are walking around and meeting folks from all different countries on a daily basis, and it's really necessary for us to take those necessary precautions.
Beautiful.
And I would just
Deborah,
drop really quickly that to do all of that also means that we are hot in budget season. So it is also up to our elected officials to make sure that they are funding community-based organizations and the niche work, and that we're being really supportive of building out these networks, but they require money and they require funding. So just want to put that plug there.
Deborah, I think that's a fantastic point. We know that oftentimes when money to be for, I know just recently in the news we're hearing that there's this ongoing conversation between City Council and City Hall in terms of where the budget's going to land. We always hear housing, we always hear libraries, we always and hear these particular needs, and those are very important. But we never hear the Department of Health. Public health is very, very important. We saw what it occurred during COVID and its need. Before we saw what happened shortly thereafter with Mpox. There's a variety of ongoing challenges that public health face. And one other thing I wanted to add that we haven't really talked about, and we don't necessarily think about this in the public health field, but it is part of that, is climate change. Having a serious impact on us in Harlem and other under-resourced communities. The heat index are going so much higher. I think 2023 was one of the hottest years on record. There's a decent chance that 2024 may will break that record, and 2023 broke the 2022 record. So access to air conditioner. And then the cost that is associated with that, being able to ensure that neighbors know the elderly and what's happening with them and how to take care of them. All of this is part of public health. All of that requires appropriate surveillance, and all of that requires funding.
Absolutely. And you know what, guys? I'm going to probably have you guys come back with some Weill Cornell folks who are part of this, what they call the green team, to talk about tree planting in under-resourced communities. But NightWatchman, understand we're going to go to a lightning round. Is that correct?
That's correct.
All right. Okay, folks, in this lightning round, what I'd like you to do is lay out your closing comments, but also if people want to get in touch with you, because you heard Deborah and what she said, money, it's all about the green, it's about the dollar bill. So, and Zacharia, I do know that one day sooner, you guys are a nonprofit organization or global nonprofit. So please tell us closing comments and also how one can donate.
Thanks a lot for that. So I think from my end, I think that children everywhere in the world deserve an opportunity to live their life. I think in Africa, it's becoming a common saying that, children should bury their parents, not the other way around. And I think malaria is taking away that opportunity for parents to watch their children grow. And we need to, get involved in trying to mitigate this problem. And then if you would like to help this work, please just reach out to One Day Sooner, just as it is written here. There's a page on the website that you can find if you like to make a donation. But thank you.
Absolutely, thank you, Deborah. Tell us. It's all, as you say, all about the money. So come on, talk to me.
If you want to find us, please follow us on social media: Facebook, CUNY-SPH. We're on Instagram, same thing, City University, School of Public Health, HHI. Eventbrite. You'll find all of our events. We're on LinkedIn, and on our YouTube channel is all of our webinars that have continuing education credits that are for free, because one of the things we didn't talk about is the shortage of the workforce in public health. So just drop that there. You can find us at any one of those channels, and we're happy to connect. We're on 125th Street in the village of Harlem. So thank you.
Absolutely. Thank you, Deborah. All right, Padmore, you got it, man.
Well, let us say thank you so much. We've been here with some great, wonderful folks. We are located in 115th and Lexington. We're the Harlem Neighborhood Health Action Center, and the concept of it is a one-shot stop for a variety of needs, health needs, as well as other social service needs. So definitely for folks to come by. We can be seen on our website. Action centers, and you'll see that there are two other action centers, one in the South Bronx, one in Central Brooklyn, and us here in East and Central Harlem. Wow. So those are the neighborhoods that are served. We continue to work and look to partner with organizations, community-based organizations, individuals. We have space, conference space, a multi-purpose room that we open to organizations free of charge. We really want to be supportive of our community to see how the various organizations that work in our community are supporting community residents and how we can be supportive of them. So we are very much looking for collaboration and coordinations with other partners in East, Central, and West Harlem.
Love it. Love it. So Night Watchman, you know what to do. You got to take us home, buddy. You got to take us home.
Okay, well, you've been listening to Soul Lounge Primetime on WHCR 90.3 FM, the voice of Harlem. Also live streaming on YouTube and Facebook. We're always on Monday nights, 7 p.m. on the radio. 8 o'clock, we live stream on YouTube and Facebook. And we try to host the most interesting conversations around what's going on in Harlem and what's going on around the world. We want to thank our guests for the work they do to keep us healthy in our neighborhoods and around the world. We learned a lot. And so if you're listening to this and you found it informational, please share this on YouTube or Facebook. And other than that, we will be back next Monday with something so interesting we can't even tell you what it is yet.
and Night Watchman, I don't want to soup you up, but you know this was a good show. This was a sure enough goodie.
Of course it was.
All right.
Yes. And
folks,
and kudos to my partner, my brother DJ LeRoy, aka Curtis Archer, for really putting together something that has impact. Wow. And I know.
Wow.
Don't have a heart attack now. That would mess the whole show up.
It would. Okay. Y'all, I love y'all, and you know you're going to be invited back to the cookout. You know this already.